This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and it's my pleasure to welcome you to this month's webinar in our 2018 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. Our webinar series helps allergy and asthma live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. Dr. Andrew Weinstein joins us today, and he'll be sharing thoughts with us on how to improve asthma adherence. Andrew G. Weinstein, MD, is Associate Professor of Pediatrics at Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Weinstein, if you move the slides forward once, they'll see your handsome face. He received his MD from the University of Pennsylvania, residency and fellowship from Children's Hospital of Philadelphia, family therapy training from the Philadelphia Child Guidance Clinic. He is a trainer in the areas of motivational interviewing and shared decision making. Dr. Weinstein is president of Asthma Management Systems, LLC, an asthma adherence, population health, and training company. For over 30 years, he has conducted research to understand how to improve asthma patient adherence. His work in pediatric asthma rehabilitation at the Nemours Alfred I. DuPont Hospital for Children led to the development of the Asthma Adherence Management Model and subsequently the Asthma Adherence Pathway web app. Merck funded an outcome study in 2014, which validated the model's web app by promoting adherence measured by electronic sensors and improving asthma control. He also received research funding from the National Institutes of Health and Keystone First Health Plan. Dr. Weinstein has been the first author of more than 25 peer-reviewed publications, including the Journal of Allergy and Clinical Immunology, their In Practice Journal, Annals of Allergy, Journal of Asthma, Family Systems and Health, and World Health Organization. He has presented his research at courses, workshops, and seminars, and at the annual meetings of the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology, as well as the American Thoracic Society. Dr. Weinstein, we're so excited that you're going to be here with us today, and we look forward to the information that you have to share with us.
Thank you very much, Sally. It's really privilege to be able to speak with you and all the others interested in allergy and asthma, allergic diseases. The focus, I guess, first I will look at the disclosure. The focus of the key presentation that I'm going to make today is that patients have reasons why they're not adherent, and that successful management requires identification of these reasons. You don't know what those reasons are, don't ask, you don't know. And the medications won't work if they're not taken. So the questions that I'm going to address today are the following. Why is adherence important? What's the extent of non-adherence? How do you measure adherence? Why are patients not adherent? What type of interventions are helpful? Are communication skills effective? And is there a management model to act as a guide for clinicians?
Dr. Weinstein, if you could either turn your volume up slightly or sit slightly closer to the computer, we're having just a little trouble hearing you.
All right. Is this any better?
Oh, much better. Thank you.
Okay. The adherence disease management is, according to the work that I've been doing, is that first you need to diagnose adherence status. The second is to look for reasons for non-adherence. Then you have to apply barrier-specific strategies to improve or promote adherence. And then finally, apply communication skills that will help implement those strategies. We define adherence as the degree to which use of medication by the patient corresponds with the prescribed regimen. Patients demonstrate a wide variety of patterns of medication use, and understanding the reasons for non-adherence will lead to effective strategies. Adherence refers to a consensual agreement or a partnership. The term compliance, which was used in the past, refers to the degree to which the patient follows the directives of the clinician without patient input. It's a one-way street, and there's no discussion. And that to be effective as a clinician, one has to be a partner with the patient. There are a number of studies that have looked and observed the problem with non-adherence. Non-adherence is associated with increased emergency department use, increased hospital care, increased corticosteroid use, greater mortality, as well as the cost of care. This is a figure that tries to point out that individuals are more likely to have a positive outcome if they're adherent than they're not. This is the measure of adherence, either looking at the ratio of controller to total medication or medication persistence ratio, medication persistent ratio by prescription refill. And these are the outcomes that were used in various studies to look to see if adherence was effective, causing that issue, both hospitalization, emergency room, and steroid. And what they had is they created an odds ratio, and they found that individuals with an odds ratio of less than 1 had a greater chance of signifying that they were adherent and having less morbidity than those not. And this more or less is I would say is a fairly strong case for the reasons why you should have patients become adherent. When you assess adherence, there are two methods, indirect and direct. Looking at the indirect, you can ask the patient to give a report. They could have a diary report. They could look at the response to treatment. You could do a pill count. Electronic monitors would be considered as an indirect method, as would be prescription refill. This is a study of 24 children with moderate to severe asthma, in which the families were asked to give a diary report each day of how often they were giving the medicine. They were also given a medication, a meter dose inhaler with an electronic device that would give an accurate report, and that the patients didn't know that they were being monitored. And what they found, there was a significant discrepancy between 95% adherence by diary and around 60% adherence by electronic measure. And less than 30% of individuals had taken doses taken at the correct time. If you break those kids up into those 16 that did not need oral steroids, their adherence was around 70%. The 8 that did, their adherence was 11%. If you didn't know what you knew about the electronic monitoring measure of adherence, you would assume that of this group of patients, 95% are taking their medicine, you had 8 cases of bad asthma. But given knowledge and being able to diagnose the cause of treatment failure, you just have 8 kids in which the families had difficulty giving the medicine. So this report, this gives you is to make the point that individuals who are on tracking devices, it makes the point that individuals don't give an accurate reference of use, and that the electronic monitor can help make that distinction of treatment failure. Now, the other way you can assess adherence is using a direct measure. You can observe somebody, you can measure a blood level, You can put a biologic marker on the medication, do spot checks, or measure clinic attendance. Of these, really, the blood values seem to be the ones that would be the most, although intrusive, accurate. This is a study that I did in 59 children with severe asthma who were placed in the inpatient hospital rehabilitation setting for 10 days and then followed for 4 years as outpatient. And that these individuals, they had a median of 7 hospital days the year prior, 4 emergency room visits. The cost was over $10,000. We had the self-management program for the 10 days and then followed as outpatients for 4 years, and the outpatient visits were associated with the theophylline monitoring. And you can see here that at all 4 years of hospitalization and emergency care was 0, and the cost went below $2,000. So being able to monitor and make the distinction between treatment failure and non-adherence with the blood levels is a method direct as well. This is a description of adherence and a figure to help understand what's going on. Here the prescription was gotten. Here is the first dose. This distance between this is the first dose, and this is called initiation. The individual took it until the last dose, and this is called discontinuation. While they were taking the medicine was persistence. Non-persistence refers to the behavior until the end of the prescribing time. This individual missed 4 doses out of 15 with the medication. Prescription refill is the most popular way to identify adherence for individuals in population studies. Two different types are used: the medication possession ratio, MPR, and the proportion of days covered, the PDC. And this assumes, the assumption is that patients, the assumption is that when you have a patient and they're taking the medicine, the behavior is consistent over time. The problem is that prescription refills don't measure behavior, and as a result, they're frequently overstate adherence. When looking at the quantity or extent of non-adherence, this is a study of over 5,000 individuals in a prescription health plan who were either prescribed either fluticasone, 200 micrograms in red, or 500 micrograms in blue. This shows that it looks at this, measures a non-adherence by discontinuation of the prescription over a 90-day period. What they found is that persistence in this group of 5,000 individuals is around 22%. But more alarming is the fact that more than half these individuals only filed the prescription once. So this is a more accurate or more depressing statement on the extent of non-adherence, and these are adults, and these adult asthmatics were selected by those having at least one exacerbation of asthma. You can see that this is a very non-adherent population, and unfortunately, the number around 20% is repeated in other studies. This is a sort of a figure from the World Health Organization in which there was a report, adherence to long-term therapy, evidence for action. And they described 5 dimensions of adherence. They had looked at the social or economic ones, which would be considered now the social determinants of healthcare, therapy-related, patient-related, condition-related, or health system or healthcare practitioner related. When looking at how to understand the causes of adherence, non-adherence, the Global Initiative of Asthma, GINA, and their guidelines and recommendations in 2008 broke this up into drug factors and non-drug factors. Drug factors consist of difficulties with the inhaler device, awkward regimens, side effects, cost of medication, dislike of medication. The non-drug factors might be misunderstanding, fear, dissatisfaction, inappropriate expectations, underestimation of severity, things like that. What the World Health Organization paper or booklet had a chapter on adherence, and I was one of the authors, and they came up with a scheme that looked at behavior rather than looked at specific behaviors. And they described 3 types. One was erratic. These individuals are forgetful, they have changing schedules, busy lifestyles. Health is not on their primary focus list. These people would be described as fairly loose. The strategies for these types of individuals would be simplification of the regimen, such as once a day dosing, if that were available, establishing new habits by tailoring the behavior to an existing one, such as brushing teeth, but it's important to ask whether that is the behavior that they have. And 3, cues and memory aids, such as cell phones. So for erratic, you try to simplify. Now, unwitting non-adherence refers to patients that you would never know that they are not taking the medicine. These individuals require clarity and education. Example of a patient with unwitting non-adherence, you might ask them, are you taking the medicine twice a day? And they would say yes. And you wouldn't know unless you said, well, please tell me how you're taking the medicine. And they say, well, I'm taking the medicine twice a day every time I'm having symptoms. So it's a communication problem, and it's the patient not being able to understand the instructions. So it's very important that clarity of instruction for this group and using open-ended questions is an important way to avoid unwitting non-adherence. Patients that I see when I tell them that they're intelligent non-adherents always smile and they like me even more because they think they're very intelligent. These individuals purposely alter or discontinue or even fail to initiate inhaled corticosteroids. This reflects a reasoned choice. Patients will say, I feel better. I'm concerned about side effects. I don't like the taste. I think the treatment is too complex. And these individuals will tell you the less medicine is, the best medicine. So irregardless of the reason that they're telling or difficulties that they're having, using open-ended communication between the patient and the healthcare provider is key. This is a schema developed by Dr. Horn and Dr. Weinstein, who are psychologists, and they came up with the thinking process of what's causing adherence problems. They came up with the idea that individuals who perceive the need for medication, such as symptoms or limitation of activity, or if they have concerns, and often about side effects, uh, this will directly affect their adherence management decisions. The contextual issues for this group will be based on past experiences, views of friends or family, practical difficulties, as well as satisfaction with treatment in the past. And that the illness perceptions, the symptoms experiences, will cause the sense to have the need, perceived need, and background beliefs, whether they're negative with the treatment or the medicine, will cause them to have concerns, and that the concerns and the needs will lead to adherence, either positive or negative. This, what they did was they validated their uh, theory by taking 100 asthma patients, giving them a question medication adherence scale, which identifies adherence, and then questions around perception and need. So that's how they put this thing together. Now, if we take a look at interventions, we're going to discuss basically three of them: therapy related, patient related, and condition related. And if you think about patient interventions, you can use medication, which we'll show you, self-management education, monitoring and feedback, and patient clinician visits and communication, as well as technology interventions. Here's a study of several thousand individuals with asthma prescribed different regimens, and they were wanting to know which regimen seemed to work best as far as number of medication days or adherence taken. And it turns out that the Advair, the combined drug, ICS and LABA, achieved around 130 days, but the Flovent and Ceravent given individually, or Flovent and Singulair individually, or Flovent individually, got around 60 to 80 days, but Singulair, leukotriene modifier given once a day, achieved about 150 days. So you can begin to see that simplicity or combining the drugs has an advantage for medication adherence. This is a study by Dr. Foster and her group, and they used a tracking device on an inhaler with a internet-related, it's like a cell phone attachment. What they did is they had two groups of individuals with severe, moderate to severe asthma, and this group, these two were monitored and given feedback about use, whether it came from a ringtone from the device or at the time of a visit with the doctor. As this group, individual did not have any of the technologic basis. And this points out that individuals who are being monitored and getting feedback will have greater adherence than those individuals who are don't have those aids. So feedback with the monitoring is helpful in promoting adherence. These are some of the devices where the smart inhaler goes around the MDI. You have the propeller attached at the top of the canister. You have pill bottles that have a circuit. So every time they're open, it releases a electronic circuit. And all these can then be used in population studies because the signals through Bluetooth technology are sent to the internet. Now, decision making, you look at it as a strategy, is to have three main features. First, it gives the patient a choice. Second, it gives them a option to discuss a range of activities. And the third focuses on whatever is giving the information which is most upfront and most needed by the patient. And they use various aids, and they wanted to know, to start with, is they asked the patient, how well controlled is your asthma? And this patient said, well, let me think. Okay, I'd say I'm moderately well controlled. Then they show them the same colored device, but they include symptoms daily, frequency of rescue medicine, limitation of activity, quality of life. And they found out that this person thought that they were moderately well controlled, but actually, according to this definition, they're poorly controlled, very poorly controlled. And it's through these types of aids one can work back and forth with the patient so as to help them achieve their goals and try to give them the instructions that they would like to follow. Now, the other type of intervention, communication-wise, is motivational interviewing. Motivational interviewing is, well, I guess we'll start out by saying what goes on in normal practice, in which the practitioner looks at the patient, sees the problem, and assumes the patient must change. Motivational interviewing is a paradigm shift in which one works and says the patient should move along a continuum of change. Doesn't have to change today or the next visit, maybe the following visit. Motivational interviewing helps the patient to resolve ambivalence, since that is a main feature in individuals who are having trouble following treatment. And the third is building motivation and confidence. And there are specific tools and skills in motivational interviewing that helps the area of building motivation and confidence. Now, ambivalence is key, and what one tries to do with the patient is to weigh the pros and cons of change. What are some of the good things about taking your medicines? What are some of the less good things about taking your medicines? And helping them resolve this ambivalence issue. So Sally, Sally, you there?
I'm here.
This isn't the full set of the slides that I sent to you yesterday.
Okay, if you want to switch to the set that you have, then you could just finish right off of those. How would that be?
Okay.
Just close this presentation and open the presentation that you had earlier that didn't have all of the other slides available to it. And you can just go right to the spot you need to start.
So let's see how we're going to do this. So I'd like to close out of this.
Or you can just reduce it down if you want to. Just, just go for the yellow button in the middle. We'll just send it down to the side.
The yellow button in the middle.
Up in the upper left-hand corner.
So I've got to go the, let's view the exit full screen. That'll do it. Then I can get rid of this. And then these are the things that I wanted to show.
Okay, great.
Let's get over here. So the last exercise with the, let me get with motivational interviewing, is the use of reflective listening. That basically is a way that lets the patient know that you're listening and trying to understand. When I was growing up and as a kid, I would watch all the doctor shows. The most effective reflective listening they offered was mm-hmm, and not very strategic, but at least they knew that the patient knew that they were working. And when you do the reflective listening, you don't know exactly, you're not sure what the patient is saying. So you say, if I understand you correctly, and then you tell them what you're thinking, and you take a guess at what they're meeting, and it affirms and validates what's going on in the patient's thinking. So I wanted to give you an idea then, now that we've presented different ways to diagnose and figure out their causes for adherence and potential treatments, is to go through a patient that I cared for in the Blue Cross Blue Shield of Delaware monitoring project, where we had a 45-year-old woman with 3 hospitalizations for asthma, had depression and anxiety, as well as marital problems. But the main problem was that there was non-adherence that was suspected by the clinician. So we evaluated the patient and gave them a monitors, a peak flow monitor, ICS, albuterol, all that was tracked over the internet. And we also, I guess that I'm interested in asking questions about attitudes and behavior. We have a questionnaire and a created software. And this area that I want you to look at, these questions refer to managing an asthma attack. It says, I follow medication instructions to treat an attack sometimes, use a peak flow meter sometimes, remove myself from the area never, but also I start treatment without delay never. Well, these I would consider as risk factors for persistent asthma. So let's take a look. We would make rounds by looking at our computer each day. This was about 2005. And we noticed over here that she had a very big drop in peak flow. Then we took a look and saw that as far as her beclomethasone going, she had started taking less and then actually stopped it. And that not only that, but she seemed to become exasperated and frustrated and even reduce the use of the albuterol. So these would have been, should have been, this is 2 inhalations, and this was done, so the total of 4 per day, and now 2. So we called her up when we saw that and had her come to the office and gave her intensive treatment. And after 1 year of working with this woman and her family, she had 1 hospitalization, the depression and anxiety continued, the marital problems continued, but we were able to address the issue about initiation and seeking acute treatment, and she became aware that we were going to be helpful and monitor her medicine use. So I recently completed my group a 3-month controlled trial funded by Merck looking at the asthma adherence disease management model. And what we had was 40 patients with moderate to severe asthma who were given Dulera, mometazine and salmeterol. And they were asked to take that twice a day. And we had the Smart inhaler monitoring with it, and they would bring back the device with the medication for review every month. And the primary outcome of this study was asthma control, the asthma control questionnaire. The secondary outcome was adherence. And the interventionist team were allergists and pulmonologists who would perform motivational interviewing. So we had 20 patients being placed in the intervention group with the motivational interviewing and the monitoring, and 20 control. We also used a web app which identified patient barriers, provided the clinicians with barrier-specific clinical decision support, gave them, the patients and the providers, asthma and adherence education. And not only did we provide motivational interviewing training for the intervention groups, but we also had 8 hours supplement in person. So it went the flow looks something like this. We would identify the barriers, initiate barrier-specific strategies, use enhanced communication skills, then we would give them, we would identify, have adherence with the monitors, and assess asthma control. They would then go out, and then at the next monthly visit, we would assess adherence. Individuals who had positive adherence and had good control, they would continue the treatment. They had positive adherence but had poor control, we would then give increased therapy. Individuals that are identified as non-adherents and had poor control, we would then reassess, have them come back to reassess the barriers. So this was how the style goes of assessing barriers, implementing strategies, monitoring adherence, and seeing what happens. So this is a figure demonstrating the asthma control over 3 months. The green is the intervention group of the ACQ, mean ACQ scores from baseline to 3 months. And in the blue is the control. And that there was a reduction in 0.75 units of ACQ in the intervention group compared to 0.19 units in the control group, and this was statistically significant. If you take a look at the adherence of the individuals over the 3 months, the mean adherence was almost 81%. And these individuals knew that they were monitored, and they continued with the monitoring. So what I'd like to do now, let's see, is get out of here and end the show. And I wanted to see if I could show you a video of some of the things that we were describing in the communication scheme. So let this warm up. There's a difference between the inhaled and the oral, where the inhaled are much safer to use.
No, I don't want Anthony on any steroid medication.
I'll just run that back because this is something that we tend to see a lot. But at this point, there we go. The problem that we're facing. But at this point, given his hospital stay, lower lung function, and wheezing, I would strongly recommend the inhaled corticosteroid medications for him.
No steroids for Anthony.
There's a difference between the inhaled and the oral, where the inhaled are much safer to use.
No, I don't want Anthony on any steroid medication.
The next segment is going to have the issue about the open-ended question. How do you ask it? And the importance of joining a family therapy technique to improve the relationship of the patient and the family, whoever's with them. Hi, my name is Dr. Jones from Asthma and Allergy Care of Delaware, and I'm interested in helping you and your son improve his asthma. Hi, James. Nice sneakers.
You should see my brothers. They're purple and red.
His name is James, but we call him Anthony.
Well, why don't we start and talk about the difficulty you've been having with Anthony and his asthma. the doctor mentioned that he's been in the hospital twice for asthma. So the key point there is, why don't you tell me about the difficulty that you're having? And what you end up getting is an unfiltered history, which is often more accurate and complete than what you would normally get.
The doctor wants to put Anthony on steroid medication, but I'm afraid to do so. My husband died from a blood clot last Christmas. He had been taking steroid medication for his arthritis for about 6 years. One day he tripped and broke his hip, and the doctor said it was from the steroid medication. And he was in the hospital for a week and then in a convalescent home for about 2 weeks. And one day I got a phone call that he had had a stroke, and 2 days later he was dead. Anthony's doctor wants to put him on an inhaled steroid, but I said absolutely not. He gave me the prescription anyway, but I didn't get it filled. And when we went back.
Oops. I'm sorry. Let's go backwards here. And I can clearly understand your concerns about steroid treatments. The history taking often is based on what the EMR question and the program looks like. All this information is easy to have if you have a piece of paper, but is not in your sequential information. She didn't know the program of your EMR, but this to me is a very accurate way of proceeding. So now what we're going to do is we're going to summarize, having examined the boy. We're going to sit down with the mother and tell her what we think. I'd like to go over what we learned so far today. So on physical examination, Anthony's having significant wheezing. We measured his lung function. The airway flow is low. It improves after the inhaled bronchodilator, the albuterol, which is diagnostic for asthma. The allergy testing, the skin testing results were negative, so we don't have any counseling advice on avoidance of specific allergens. But at this point, given his hospital stay, lower lung function, and wheezing, I would strongly recommend the inhaled corticosteroid medications for him.
No steroids for Anthony.
There's a difference between the inhaled and the oral, where the inhaled are much safer to use.
No, I don't want Anthony on any steroid medication.
So, according to the education, the decision making, patient centered decision making, you give the patient a choice, and that is basically what we're going to do. I guess the alternative to consider is a non-steroidal anti-inflammatory medication, a leukotriene modifier. We would want him to take one of these tablets at bedtime, but it is clearly not the so-called best treatment for his severity of disease. But if we go with this plan, I'd like to have him monitor his lung function with a peak flow meter, which will show you how to use. And very importantly, if he continues to have symptoms or worsens, I'd like you to phone the office here for further instruction.
We'll do whatever we need to do as long as there's no steroid medicine.
So we're going to close out with the patient comes back, and you're going to find out how things worked out, and you're going to, I'll be doing the concept of reflections back to the mother and as I'm listening to what she's saying. Good morning. How things work out? Hi, Anthony.
Hi. Oh, not so good.
So Anthony's not doing so well.
He still continued to have some coughing at night and during the day. His peak flow values have been in the 180 to 210 range, and I think you had mentioned they should be in the 240 to 250 range. I've been giving him the albuterol in the morning, and the school nurse gives it to him at lunch and before recess in gym. But she said she's worried and says that I'm damaging his lungs by not giving him stronger medication. And I'm just miserable. I don't know what to do.
Worried and frightened.
I want Anthony to get better, but I don't want to give him the steroid medicine.
You want to do the best for him.
Yes, and that nurse wants me to give him the medicine that killed my husband.
That nurse appears to really upset you.
She did.
The nurse discussed the corticosteroid medications with you?
She said Anthony needs that to feel better, but I feel like I'm in a bind.
So if I understand you so far, Anthony's asthma has caused him to have frequently missed school, emergency trips to the doctor, deficiency, not doing well in sports. But on the other hand, you're concerned about the safety of the inhaled corticosteroids.
I know, it doesn't make much sense, does it?
So I'd like to stop there. I think what I tried to do today was to give you an idea on how you might approach patients who are having treatment failure, how you would diagnose whether they were adherent or not, and using the advantages of using electronic devices, which are expensive, but for the most expensive patients seem as a possibility. And then finding out why it is that these individuals are having problems with following treatment. And then once you identify, then you can have a strategy that will work for each barrier. And enhanced communication skills will more or less facilitate or optimize the strategy presented. So I think I'll stop there, and if there are any questions, be happy to answer them. Sal, are you there? Sound good?
Okay, just one moment, please. Okay, can you hear me again, Dr. Weinstein?
Now I can.
Okay, I don't know what happened, but every once in a while, technology gets a little interesting. Okay, so the first question you have is going to be, what blood test is recommended to assess inhaled corticosteroid adherence?
There is none. So that's no blood test is for the inhaler. You would want to be using the electronic monitor.
Okay. Do you favor the use of Eros chambers and spacers in the school setting?
Sure. I think that's very helpful, especially if someone's there to help the child use it correctly.
Okay, sounds good. Our next question is, it says, well, I don't know if it's a statement or a question. It says, I'd recommend the specific prescribed number of puffs and frequency be written on all prescriptions, as family often don't remember what it means to take something as directed. Do you agree with that?
Yeah, that would be helpful, especially let them know that in case they forget, they can see it right there.
Sounds good. And just so that you know that, Dr. Weinstein, that I took the presentation slides back over so that I could show the remaining slides. So, so now we're going to view my screen instead of yours for the duration. Okay, so next question is, how often do you do case studies? Is there a way to be included in one of your case studies?
We aren't doing case studies. We work with health plans to train nurses and doctors and health coaches how to use the software and the tracking devices and the motivational interviewing. We're not doing any case studies per se.
Okay. This person says, it looked like you used some electronic monitoring for adherence. Are those covered by insurance? And did you look at the return of investment on the adherence approach?
Yes, they would have, they're on a case by case basis with the insurance companies. If they have a patient of significant cost and they feel that the person or team using the care with this device will be helpful in reducing the cost, then they will permit it to happen. My experience is with my clinical practice number of studies, the return on investment is $3.3 saved for each dollar expended.
Okay. The next person is saying, I work mostly with adolescents. I have many that do not adhere to their asthma meds. I see them repetitively for treatments for asthma flares. At each visit, I have them fill out the asthma control test, then have a conversation with them about their control. I show them visuals of how lungs look for people with and without asthma and have them tell me what differences they see. I do a demonstration for them on how to use their inhalers and how to use every different type of inhalers. I try to use motivational interviewing with them. None of this works. They keep not using their inhaled corticosteroids. They can't give me an answer as to why not. The answer varies from visit to visit. I'm not sure what to do. Can you help?
Yeah, I guess refer them to another group. That was a joke.
Okay.
What you can do is there's all sorts of. My background includes family therapy training, and one of the tricks that I've learned in selective cases is more or less to sort of like child psychology. You tell the person not to do what you want them to do it and see what the response is, because they'll usually say, well, that's stupid, I'm going to get sick. Then there's another follow through that, which requires a lot of sophistication, because it is a paradoxical intervention. Paradoxical intervention more or less says don't use the medicine because, and then you understand the child's or the parent's situation well, and you understand that, tell them that if they did start taking the medicine, their lives would be changed. Instead of being considered sickly and poorly outcast, they would be considered just somebody who didn't take the medicine. So it would be important then not to take the medicine. And then I published papers about that, and it really works, but you really have to know what's going on, to say the least, with the family.
Okay. Your next question is, as a community health worker, how can I get more information regarding the training you mentioned, and are your apps available for wider use?
Right now, we're developing the apps for wider use. It's not available now. The training, we're not doing any specific training at this time. It's possible that we will begin doing offering that type of training, possibly over the internet. And when the software is finished, we could then make it available. But I think the idea of the software is you have to find out what's going on, and if you don't know, you won't know. So it's a nice, clean way to do that.
Okay, our last question is, did Anthony's mother ever agree to put him on inhaled corticosteroids?
Yeah, we just ran out of time.
Okay, so I'm glad someone asked what the end of the story was.
Yeah, what happened is that what you do in the shared decision making model, but also patient-centered model, is you go along with the patient or mother, what they want to do, but they won't do choice one. You give them an alternative. In this case, the leukotriene modifier, and it didn't work. So when they come back, they seem to be more interested in following up with choice one. And that's pretty much what happened here.
Okay, well, the last comment that I can share, we had more questions, but we just have run out of time. The other comment was hearing a real patient interaction was very valuable. So, Dr. Weinstein, I'd like to thank you so much for everything you shared today, and I'd like to thank our listeners for listening today. And at this time, if you haven't downloaded your handout or your certificate from the control panel, please do so, because that will be unavailable after we finish the webinar. Please join us next month for our December webinar when Dr. Ann Maitland will present on asthma disparities and living with asthma in modern society. This webinar will air on Thursday, December 13th at 4 p.m. Eastern. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page on our website. Visit our website for quality, guidelines-based resources on allergy and asthma. Also, access important medical information on allergy and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We hope you have a great and a healthy day as we work to breathe better together.